So I think we will begin now. Good evening, everyone, and welcome to another webinar hosted by the Greenwich Hospital Medical Library. My name is Veronica Belenkin, and I'm the Consumer Health Librarian at Greenwich Hospital. Tonight's topic is on the subject of menopause, preparing for it, and what you need to know. And I am joined by my esteemed local gynecology experts, Dr. Huang and Dr. Hagberg, to hopefully enlighten all of the people in the audience. A general overview of menopause, some symptoms that are associated with it, what health risks are associated with it, and to hopefully combat some misconceptions and negative stigma that is associated with this very important stage in every woman's life. And I would like to begin by briefly introducing us and what we do and what our roles will be in this presentation. But before that, I just want to point out that there will be a dedicated Q&A section at the end of this presentation where myself and my experts will answer questions, but please save your questions till the end of the presentation. And you will be able to access your Zoom taskbar and click the Q&A icon in order to ask your questions. And during some brief engagement activities, you may use the Zoom chat icon in order to submit responses. So you have two options with which to engage during this presentation, and I will let you know when you're able to. I will be reminding you of the Q&A portion. Then again, the Q&A will be at the very end of the presentation. So I'll start with myself. Like I said, I'm the Consumer Health Librarian at Greenwich Hospital. Some people may not know this, but there is a medical library on the first floor of Greenwich Hospital, and it is one of the only medical libraries in Fairfield County that has a special section just for patients and families to receive health information. And that is primarily what I do. I help find accurate information that you may be able to share with your healthcare provider and be able to be a more informed patient and be more involved in your healthcare. As a result, be able to have more productive dialogues with your healthcare provider. One of the ways in which I promote health prevention and wellness education is through these webinars that I'm able to do, and I collaborate with healthcare providers in the Greenwich Hospital and Greater Yale New Haven Health System. And I do this because I do want to help people become better advocates for their own healthcare and to be more educated and thus make better healthcare decisions as a result. And I do really care about this community and its residents around Greenwich because I myself am a Greenwich resident who enjoys walking and listening to audiobooks and reading graphic novels, of which one of my favorites we will be using and presenting in this webinar. So hopefully you will like that. Next, I would like to introduce or have her introduce herself, Dr. Huang, our resident gynecologic oncologist. Please, Dr. Huang, briefly introduce yourself.
Thank you so much, Veronica, and welcome to everybody. Yes, I'm a gynecologic oncologist, so I specialize in women's health, specifically women who are at higher risk or diagnosed with a gynecological cancer. I'm an associate professor of OBGYN and reproductive sciences at Yale School of Medicine. Actually, coming full circle, started my undergraduate and I graduated from Yale College before spending some time on the West Coast and then coming back east, which is home for me. And I too am a Greenwich resident and very much want to help to join Veronica's efforts to make information about staying healthy accessible to the community, and hope that you'll enjoy our webinar.
Well said, Dr. Huang. I always ask this of each of my guest speakers. What made you interested in this particular field of healthcare, specifically gynecologic oncology?
When I was a medical student, I had the opportunity to spend some time on the gynecologic oncology floor, working closely with the GYN oncologists, and really was inspired by the courage of women facing a GYN cancer diagnosis. And I really wanted to help find new cures for GYN cancer, as well as help women who are facing GYN cancer.
It's a very specialized part of gynecologic care, so there's definitely a need for persons like yourself. So we really do appreciate anything that you can inform us about with regards to that tonight. And next we will have our other resident expert, Dr. Hagberg. Dr. Hagberg, would you like to briefly introduce yourself?
Sure. So I went to the undergraduate at St. Lawrence University and went to medical school at the University of Rochester. And then I went to Yale, where I completed my residency. And then I moved to Greenwich, where I have stayed ever since. And I love being a part of this community. I'm very honored to be here tonight. Thank you so much, Veronica. And honored to be a part of this panel with Dr. Huang as well. I love this field. I love the topic of menopause. It's important to me. And I think it's really nice that I have an opportunity to talk with people who are here today to share my insight and some of the thoughts that I have on keeping everyone healthy for as long as we can and throughout the perimenopausal years, as well as into menopausal years. And what drew me to this field is during the rotations during medical school, you rotate through all the different subspecialties and just loved every single one of them. And I found that the field of GYN really merged everything together. It was surgery and pediatrics and GYN and psych and internal medicine, endocrinology, and preventative care, and spending a lot of time with patients. And I just really enjoyed that whole aspect of this field.
And we're so glad that you do, because I'm sure people have a ton of questions on this topic. So I'm really looking forward to hearing what insights you both will bring. So, and I'm sure that I'm also really happy to see all these interests that you have. I hope you have enough time to actually do them in your spare time with all the patients you two probably have. So that's really great how much of a broadness of interest you can still have while still maintaining this kind of job. So I was really glad to see that as well. So with those introductions out of the way, we have our overview of tonight's presentation. And I just want to make a quick disclaimer that this webinar is designed for educational and informational purposes only. Please consult with a healthcare provider before making any changes that may impact your health, whether it be with these two, a gynecologist or whatever gynecologist you already have on hand. All the information here is meant to be shared with that healthcare provider. So we will be beginning with the general question of what is menopause, kind of just debating and kind of just explaining what fact is versus the fiction that may have been emerging about menopause. We also will be going over some common symptoms that occur during the menopause stage. Dr. Huang will definitely bring us a lot of insight onto the gynecological health risks and also provide some healthy preventative measures that can be taken. We will also be dedicating a portion to how to manage menopause, the pharmacological methods, what methods of self-care you're able to do to manage menopause, and also a very important discussion on hormone replacement therapy. That's what HRT stands for. I will be recommending some online resources and books that anyone in the audience can look into in their spare time to learn more. And last but not least, our Q&A with us, your speakers tonight. And I will be managing trying to manage the time to make sure that we have enough time for that. So wish me luck on that. In the meantime, there will be a couple of panels in this presentation that I will be sharing from the award-winning graphic novel Menopause: A Comic Treatment. I will highlight certain panels from this book. It's an anthology book edited by a nurse, M.K. Serwick, and both Dr. Huang and Dr. Hagberg have also received this great graphic novel and have spoken to me about how valuable this is from a patient perspective to know exactly what a variety of women from the LGBT community to anyone from young to old, their perspectives on what menopause actually is to experience. I do like to use comics in education because they are able to visually educate and provide a window into the patient's experience, especially with certain health issues that may be considered taboo or very difficult to talk about. So when a panel from this comic comes up here during this presentation, please feel free to share your thoughts on it or respond to the discussion prompt that I will be throwing in there in the Zoom chat that is on your Zoom taskbar. This is entirely up to you if you'd like to proceed in the discussion. So we will start with a panel from this comic, as I spoke about. This is a panel from the comic in the graphic novel, Menopause, a Comic Treatment. It's called When My Biological Clock Stopped Ticking by Monica Lalonde. For those of you who may not be able to see it clearly, I'll just read it briefly. So my own menopausal process, phase 1. Oh my God, am I pregnant? My periods had always been as regular as a clock. Being late had only ever meant pregnancy to me. I got scared several times until the penny dropped. I am not pregnant, silly. I am perimenopausal. So my discussion prompt for this panel is, what stands out to you the most in this panel? It could be the wording or the illustrations. Dr. Huang or Dr. Hagberg, what stands out to you as gynecological experts in this panel?
She looks very confused and really scared. And the word perimenopausal, I think, can be overwhelming and means a lot of different things to a lot of different people. And they might find that whole process brings an end to the reproductive period of their lives, and it can be really, really concerning and really scary. So the definition of perimenopause into menopause is going to be an important thing for us to talk about.
Definitely. Dr. Huang, any thoughts?
It's talking about how the periods were changing. So some women do notice, and it can sometimes be years before menopause actually, that the cycle may, one of the common changes is that may become shorter. So people who've always been used to having their periods start on certain time of the month, that may start to shift. So it's not uncommon for the cycle length to get shorter, sometimes years before menopause actually starts.
Yeah. And I'm sure that when we're told, like most of our young adult life, that no periods means pregnancy, obviously the first conclusion that somebody might come to is being pregnant, which can be pretty scary. But it's I don't know whether patients that I've seen both of you have expressed relief at whether they're also possibly menopausal. So that's really interesting to know, like whether that actually gives them more relief or it gives them just as much anxiety to know that. So I always wonder that, in case of the doctor's office, would you rather be pregnant or would you rather be menopausal? So I really like that, how clear the illustrator of this and the author of this panel highlights how anxious this kind of news might make somebody. But of course, that's just phase 1. There's a whole other stage. It's not even part of menopause just yet, as we will discuss now on this slide. So menopause is when the periods stop permanently and you can no longer get pregnant. So according to the Office of Women's Health and Very Well Health, an overview of menopause, women reach menopause after 1 full year without a period. And that perimenopause, which was mentioned in the panel, precedes menopause and refers to the time leading up to your last period. And according to NAMS, the North American Menopause Society, the average age for menopause in the United States is listed as 51. And after menopause, your ovaries make very low levels of hormones of estrogen and progesterone. And the gradual loss of these hormones can raise your risk for certain health problems. So Dr. Huang and Dr. Hagberg, is it possible to expect menopause earlier than that average age that is stated by NAMS and other organizations?
Yes, menopause can occur in the average age is 51, yes, but many women will experience menopausal changes, perimenopause, especially in the early 40s, and some women may not experience anything until their late 50s. So there's quite a range, actually. The time that they experience symptoms during the perimenopause can also vary. They may have it just for a few days. They may experience it for 15 years. And the average length of duration of perimenopausal symptoms is about 7 years. The average diagnosis is made at around 51. And that diagnosis is made, yes, 1 full year of no period. And then we would call that patient menopausal. But it does vary. I've got many women in the early 40s symptomatic. Dr. Huang is absolutely correct. One of the very first signs that I'll see is that the interval from the beginning of one period to the beginning of the next will shorten. So they're typically going to have in the past a 28-day cycle as an example, and now they're noticing that their cycles are 26, 25, maybe 24 days, even down to 21-day interval. The flow usually stays the same. During that time, they may have some very subtle changes of feeling a little bit warm at nighttime. And then later on, their cycles will start to skip in space.
So again, oh, I'm sorry, go ahead.
Yeah, no, not at all. Yes, I just wanted to comment. It talks about some of the potential health problems. One benefit of not having periods is women are less prone to anemia. So some women during the reproductive years, especially with low iron intake, are more likely to become anemic. Without even if it's a smaller amount of blood loss during the menses every month, anemia becomes less common.
That is certainly a benefit. So, and when it comes to menopause, there's always the good to look at a silver lining like that. So that's very important to know. Thank you for sharing that. Other than that, it is the primary cause of these symptoms that maybe people be suffering from is the lower levels of hormones that continue to decrease as you age. Unfortunately, there's not much we can do to stop it unless the certain therapies or treatment options are presented, which we will discuss further into the PowerPoint. Before that, we move on to our typical symptoms, but I wanted to reflect on a specific, how far we've come in terms of regarding menopause. And I wanted to draw the audience's and yours attention to this comic from the 1950s, where you can see that just based off the cover, the typical perception of a menopausal woman is not one who's very happy or excited. The typical look on her face would indicate that most people perceive menopausal women as angry or annoyed, very emotional, upset. And that's also verified within the further pages of the book that state that almost like as if there are symptoms, easily overwrought, irritable, jealous, argumentative, nagging, depressed, melancholy, almost like they're listing the symptoms of what menopause might be associated with and how it transforms women apparently into these angry people. I don't know about Dr. Huang, Dr. Hagberg, but how many of these patients would you describe any of these in? Maybe none, hopefully. But
I was
80% of women will have some of these symptoms. Actually, it's pretty significant. Sorry, Dr. Huang, go ahead.
No, not at all. I guess the way that it's presented here, I looked at the author to see if this was a man or a woman author, because it seems to be putting it in such a negative light.
it might be certainly the case when people come in at first to see you, and but what would help with the understanding is knowing exactly what symptoms might be causing somebody to feel this irritable or depressed or argumentative. So with that being said, we can go over other misconceptions that might be present when it comes to learning about menopause. Menopause is not a disease disorder, and that is a fact. It is just a normal stage in a woman's aging. If there is a test to diagnose it, I've heard that is the case. I don't know if Dr. Hagberg, Dr. Huang want to go into a little bit of detail about how exactly it is diagnosed.
Well, it's a clinical diagnosis. So menopause is clinical, meaning it's 1 full year of no period. And then we would diagnose that patient as being menopausal. Testing can be done to support that diagnosis. And FSH can be run, follicle stimulating hormone, estradiols can be run, but the diagnosis is clinical.
Yes. Okay. And with menopause that can be caused by surgery, chemotherapy, and radiation, I'll leave to Dr. Huang to perhaps describe why that is in fact a fact.
Yes, so in certain instances, the ovaries may need to be removed surgically, whether it's for cancer prevention or because of an issue that has arisen with the ovaries. And so, yes, certainly there is surgical menopause if both ovaries are removed. Interestingly, if one ovary is removed and one ovary is retained, that does not cause menopause and does not cause significant changes in the hormones because in fact, usually from month cycle to cycle, it's random which ovary produces the dominant follicle and then is actively producing hormones. And so if you have one ovary, you'll ovulate if you are ovulating regularly from the same ovary every month. Yes, so surgical menopause, unfortunately, because it can be very sudden, can cause, lead to more noticeable menopausal symptoms. And many chemotherapies do not induce menopause, but for those that can affect the ovarian function, it's more likely to induce menopause in women who are already perimenopausal. Radiation, not the kind of radiation for diagnostic procedures, which is very low, like chest x-rays, abdominal x-rays, and CT scans, but therapeutic radiation, where high doses of focused radiation are given for treatment of diseases such as tumors or cancer, would induce menopause if the ovaries are in the field of the radiation, because the ovaries are very sensitive to radiation.
And of course, this would be something that would be discussed prior to doing the surgery or chemotherapy or radiation, this particular risk. Yeah.
Right.
That's always good to know. Before actually going into that, always want to know what the outcome will be. So next we have people with menopause are never happy and always angry. And that's, if somebody had read that comic from the 1950s, perhaps they would know this. But as a matter of fact, a lot of people state, especially those websites that I mentioned earlier, that it might be a fiction. A lot of the time, I believe those symptoms, if not managed, may prevent somebody from feeling as happy as they would be. But that is why we're dedicating a major portion of this PowerPoint to discussing the management techniques. Decline in libido is guaranteed during menopause. That is also considered a fiction. And symptoms such as weight loss, weight gain, trouble sleeping, hot flashes, and menopause are inevitable. Also fiction. So Dr. Hagberg, Dr. Huang, why might that be the case? I thought, menopause was supposed to be the worst time in a woman's life based on, comics such as that one that we saw. Why is that a fiction? That certain these symptoms aren't guaranteed.
Most of the symptoms that occur with the transition of perimenopause into menopause are due to the loss of estradiol. And the estradiol is predominantly made during our reproductive years in the ovaries, but there are other areas in the body that can make estradiol, and the ovaries do continue to make estradiol into the menopausal years for many women. There's a lot of things we can do, and suggesting for things that you can do just on a day-to-day basis that may optimize your own body's endogenous production of estradiol. We're going to get into that, I think, later on during this presentation. And I think that's really important for us to know, because if we can maximize our own body's production of estradiol, we can eliminate a lot of the symptoms that occur.
Which is, I'm sure, very happy that for women to hear. And with regards to the common symptoms, I've listed some of the ones that are most commonly present for some people, because everybody's an individual. Some of these may be more pronounced than for others. And I do recommend that for those people who are experiencing certain symptoms, to definitely put it on record, either with this menopause symptom questionnaire from the Menopause Charity website or from the NAMS health questionnaire. The NAMS health questionnaire in particular is way more in depth. It asks questions like, what's your family histories of health? What's your healthcare provider's contact information? It helps you fill out exactly what you want your gynecologist to know, way more in depth on the symptoms. Dr. Hagberg or Dr. Huang, is there a particular order in which these symptoms might occur? And also, which symptoms would you say could be the most prevalent, especially for somebody which might help somebody know whether to go in and talk about this particular concern?
Yes, there are 10 stages of perimenopause. There's some really early stages and there's some really later stages. But in general, the early ones are going to be the cycle changes where the periods are initially coming more often. The flow should stay the same. And eventually then probably middle of the 10 stages is probably going to start to skip in space. The night sweats come sooner than the full-blown hot flashes. And this is really what people are just feeling just generally sweaty at nighttime. And it's surprising to them. They're used to sleeping with their socks on, and then suddenly they're just feeling they're waking up just a little bit more sweaty than they're used to. The mood changes occur because the sleep is interrupted usually. So they're waking up feeling these sweaty moments, and then that they're tired the next day. They're then reaching for unhealthy food just to kind of keep them getting through the day. And that actually can just continue to lead to the weight gain and some of the slower metabolism, and then just not feeling the same. The later changes are the vaginal dryness, the loss of the hair, and some of those other ones will come much further down the line with painful intercourse and the bladder issues.
Mm-hmm. So when you would prefer that people would come in sooner rather than later. So if they would come in with something like night sweats or chills, do you think that's enough cause to speak to their gynecologist about menopause?
Yeah, they should go in. They should go in and talk with them about it. What can they do from a very natural standpoint to try to, again, maximize their own body's production of hormones? And sometimes they really don't feel well, and we can balance them during that time as well. But they should go in, even with the period skipping, they should be going in.
Yes, I agree. So next we have another.
I like the idea of being.
I'm so sorry, Dr. Huang. Go ahead.
No, yes, I like the your suggestion of really having an idea of what the symptoms are and what's bothering you most, because that can be helpful for how you approach how to alleviate those symptoms. So yeah.
Yeah, especially if it's the hot flashes, because most of the panels in the comic treatment graphic novel heavily talk about the symptoms of hot flashes. That seems to be the most prevalent among the women in the graphic novel, at least. This one in particular goes into very great detail about the stages of a hot flash that she experienced. For instance, headache, anger, a certain type of hungerness and lightheadedness first, thirst, early heat, raging heat, chills, and anger, mentioned 3 times in this one panel. Seems to be a common occurrence. I don't know if there's any symptoms of hot flashes that stand out or may surprise people, but yes, the raging heat seems to be the most common, at least for the women in the graphic medicine graphic novel. Dr. Huang, the author of this panel, states that these hot flashes are a result of getting estrogen positive breast cancer at 25, and the panelist says that she was put into menopause to prevent such a reoccurrence. Could you maybe briefly go into describing like why menopause might have been the way to prevent such a reoccurrence of this cancer?
So yes, what's called endocrine therapy, so hormone-based therapy or hormone blocking therapy, is specifically used for hormone receptor positive breast cancer. So not for all breast cancers, but some breast cancers have receptors so that they can be stimulated by circulating hormones. So there are different types of endocrine therapies to selectively block the effect of the estrogen on the breast cell, or there are other approaches that lower the body's own endogenous production of the estrogen, or there are other ways to to block and suppress the ovaries. And sometimes those are used in combination. And yes, and definitely suppression of the ovaries and some of the medications can bring on menopausal symptoms.
And Dr. Hagberg, do you have anything to add to this particular panel?
No, I think it's kind of fun to look at it, and definitely I think the chills are secondary to the loss of estrogen, because the whole thermoregulatory zone in the hypothalamus is just triggered by that loss of estradiol. Estradiol is that bioidentical hormone that's coming out of the ovaries that's endogenous that Dr. Huang is talking about. That is a growth hormone. So if you have someone who has cancer that has an estrogen receptor on it, you can block its growth by blocking that receptor. And I think that's what they were referring to, that question. And that's an important step in treatment. It's the first step in treatment, actually.
Yeah, it's amazing how just a slight difference in hormone can just completely affect the body in this way, which is why management is so important. And with regards to that specific panel, the specific gynecological cancer was mentioned. So that is amongst that certain health risks that may increase during the menopausal stage in women. The others include cardiovascular disease, osteoporosis, obesity, even Alzheimer's disease, and like we mentioned, certain cancers, breast, endometrial, and gynecological cancers, the 5 that are mentioned here: cervical, ovarian, uterine, vaginal, and vulvar. Dr. Hagberg or Dr. Huang, could you talk just briefly about why these specific health risks may increase during menopause?
Well, our biggest health concern is cardiovascular disease in the menopause. And from that final menstrual period, our risk for cardiovascular disease rises. That's predominantly the loss of estradiol. Osteoporosis, same. When you look at bone densities that are performed in women as they age, our bones thin immediately once we start losing estradiol. It's a great bone remodeler and a bone grower. Obesity, that is complicated. There's a lot that's happening at that time in our lives. Usually the kids are growing up. There's a lot of stress. They're leaving. We're aging. There's just a lot that's happening. And obesity is, there's a slowing down in the metabolism and a little bit of fat deposition. There's more cortisol. The stress, whether it's from physical stress or from emotional stress, or even the hormonal trauma that can occur from the loss of estradiol, the cortisol can cause a fat deposition, usually in the mid-abdomen. And that's always disappointing. Alzheimer's, there's some really good research going on right now with estradiol and its effect on brain tissue in the menopausal patient, especially the perimenopausal patient. It can function as an antidepressant. And right now, there's no real scientific strong data on it, but they're looking at whether or not the cognitive decline that can occur in the menopausal patient is related also to that loss of estradiol. And in regards to the cancers, I'll let Dr. Huang jump in there and start talking about that.
Yeah, I wanted to mention this because during reproductive years, there may be more regular reminders and prompts to go to the GYN for the well woman visit, to get the refill of the birth control pills, or, some of the screenings happen before, during, or after pregnancy, for example. So Pap smears are such an important way to screen for and prevent cervical cancer, because the goal of the Pap is to detect very early pre-cancer changes and intervene before there's ever an invasive cancer, and has been highly effective at greatly reducing cervical cancer in this country. So yes, cervical screening by PAPs is still indicated, and often these days is done in conjunction with an HPV test. Of course, younger people have access to HPV vaccines, which are also highly effective preventive measure to prevent cervical cancer development. Ovarian and uterine cancer are 2 of the cancers that do greatly increase in the perimenopausal and postmenopausal years, and are much less common during the younger age and reproductive years. So, I'd always like to make sure that women know that after menopause, any onset of vaginal bleeding or spotting should prompt a GYN evaluation because that's an abnormality. It may be due to a benign abnormality like a polyp or benign growth, but it may be a warning sign of an endometrial precancer or cancer. So definitely, don't ignore vaginal spotting or postmenopausal bleeding or even discharge that's unusual.
Mhm.
Yeah.
That is why this chart from the CDC of the Gynecological Cancer Basics is so helpful, because there may be certain types of symptoms that are harder to spot than others, and they may be happening in conjunction with other menopausal symptoms. So it's definitely important to know ahead of time what to look for and what to be careful of. So with all these health risks, it seems like, based on what Dr. Hagberg and Dr. Huang described, menopause isn't going to directly cause these health risks. They are just going to help increase them as we age, unfortunately. And managing them is why it's important. The management treatment is important to discuss as well. So,
And I did want to mention, I see very nicely you have on the slide the colorectal and breast cancer screening,
yes.
which we implement in the perimenopausal and postmenopausal years. So colon cancer screening, there's a big change that colonoscopy and colon cancer screening is preferred to start at age 45 in patients, people without any specific risk factors. Of course, people with specific risk factors or hereditary risk may need to start at a much earlier age, but for the general population, that age to start screening has been moved from 50 to 45 because we are seeing a higher incidence in colon cancer in younger people. Of course, some of the ways that also lower the risk are high fiber diet, eating a lot of vegetables and fruits. And then breast cancer screening, we're fortunately an effective way to detect many breast cancers at a precancer stage or at a very small stage where it's very, very treatable. And so for that, then that's mammography. Because of mammography, most breast cancers are detected at the earliest stage, stage 1, and that really can make a huge difference in the outcome. So again, just the annual mammography is very important. And I encourage women to discuss with their GYN, even without family risk factors or other factors, considering starting mammography at age 40 or as you and your healthcare provider decide.
And just to clarify, this specific type of screening should occur once a year after that age limit has been reached, or does the frequency of the screenings increase as we age, or it just stays one per year?
So there are different guidelines out there that vary a little bit. So some recommend annual screening after age 50, and others recommend starting at age 40. Every year or every 1 to 2 years.
Okay, yeah, I guess it could also depend on the individual as well, but yes, that's really important to emphasize that the screening should start around that age for sure. It's interesting that you mentioned nutrition, the high fiber diet and such. Obviously that's under the impact of maintaining a healthy lifestyle, but as you will see in the next slide on managing menopause, it's actually an important part of self-care of the managing of menopause. We have listed nutrition, mindfulness, meditation, hypnosis, even getting enough sleep, any type of stress relieving exercises such as Tai Chi, yoga, and Pilates, and even an exercise of Kegel daily. Dr. Hagberg, maybe you could go into a little bit of detail on each of these self-care and what specifically, if a patient comes to you, would you recommend with regards to certain types of self-care? I know you have some thoughts on the nutrition, for example.
Yeah, I do. So, I always want to primarily focus on nutrition first. There's a number of things that patients can do on their own, and that's the first one. So as far as looking at what they're eating, what they're putting into their body. I'm really going to encourage them to pull back on saturated fats, to pull back on carbohydrates, and really focus more on the vegetables, some fruits and vegetables, protein, complex carbs, lots of whole grains, nuts, things that are really going to help give them the really basis of what they need in order to build their building blocks throughout the rest of their menopausal years. And we live longer and longer, which is great. And we want to stay really healthy and we want to feel good. The second thing that I would love to focus on is exercising on a daily basis. And I love these exercises. There are 3 generalized types of exercise. There's the aerobic one where you're sweating and really getting your heart rate up. There's the muscle building one, and Pilates and yoga does a lot of that. And there's a lot of relaxing types of exercise as well. And I think during transition, during the perimenopausal years and into menopause, it's important not to do too much of the traumatic types of exercise, but focus more on some more milder aerobic and really the muscle building and more of this stress relieving types of exercises. Getting enough sleep, huge. So there's a lot of rebooting that's happening during our sleep phase. And I think that it's important for us to try to get enough rest. I think sleep interruption is a problem for many women. And we usually talk about ways to meditate during those insomniac nights so that they can really feel at least that even if they weren't in a deep REM, that they actually feel quite rested the next day just because they've been restful and meditating. Spend a lot of time talking about that. Hypnosis is actually one of the things that has been researched and proven to be helpful in reducing a lot of the symptoms of menopause. And a lot of people don't realize that, but we'll probably hit that, I think, on a future slide, but I like it. And Kegels, of course, helps to strengthen the pelvic floor, builds a lot of those muscles to help prevent some of those symptoms that happen in the menopausal years, especially with the bladder health, but it also improves blood flow to the whole pelvic anatomy. And that can improve a lot of different things for the menopausal patient.
And you can even do a Kegel exercise when you're on a Zoom meeting and no one will know.
That's a really good point, Dr. Huang. Do you have any thing to add before I move on to the next parts of the slide, Dr. Huang, with regards to self-care techniques?
Yes, I just thought in terms of getting enough sleep, some women have their sleep also disrupted by getting up at night to use the restroom. And so I encourage women to hydrate a lot in the early part of the day and try to stop hydrating in the evening. And that can sometimes be helpful.
And I did put hypnosis there for a reason, because I knew it would raise a lot of eyebrows from people, but it is great that Dr. Hagberg does herself encourage it. It is considered as complementary therapy. So there are many herbal substances and products that have been suggested as therapeutic agents, but most are not FDA approved, or they lack scientific evidence or efficacy, which is why it's so important to ask somebody like Dr. Hagberg or Dr. Huang, are there any alternative medicine treatments you would recommend to try to relieve my menopause symptoms? Hypnosis being one of the ones that just have some studies to back it up. I've also, with these hormone network alternative medicine for menopause treatment, and also from the National Center for Complementary Therapy, they do have specific sections just on complementary therapies used for menopause treatment. Of course, we highly recommend to not try these on your own, but again, to ask ahead of time with your doctor, depending on what your treatment plan is, to ask them what they suggest or recommend, because some of these have been known to disrupt or impact the treatment. So it is definitely important, if you're going to try a complementary therapy, that it complements and not disrupts the actual treatment in progress. And one of the treatments that I think a lot of people need a little bit more expertise on is the pharmacological and hormone treatment side. For instance, there are antidepressants such as Prozac or Brisdel that may be recommended. There is a medication to alleviate certain health symptoms such as osteoporosis. And there is also the hormone therapy, estrogen only, or estrogen and progesterone, and also vaginal estrogen as local management for the specific symptom of vaginal dryness. I would like to ask Dr. Hagberg or Dr. Huang if there's any specific treatment they would like to focus on. And I will also specifically ask specific questions regarding hormone replacement therapy. But before we move on to hormone replacement therapy, is there a specific treatment you'd like to give a little bit more information on?
Well, I'd like to mention cognitive behavioral therapy as well. I think that is another important alternative complementary therapy that has been researched and proven to be helpful. GABA is mentioned here. There's another one that's called remifemin or black cohosh, and that has also been researched and proven to be somewhat helpful. I find that they can take an edge off it. They're not going to necessarily completely reduce some of the symptoms, but it can sometimes help patients get through that transition and just make everything a little bit more manageable. Brisdal is Paxil. That's actually been marketed for the transition into menopausal for the hot flashes. And all of the SSRIs. I particularly will talk a lot about Wellbutrin, which is not an SSRI, but it does actually really significantly help the symptoms of hot flashes and night sweats and sometimes depression, but it doesn't have any particularly negative side effects for libido. In fact, it can have a reverse improvement with libido, where some of the other SSRIs can have a negative impact on libido. But when we're talking about quality of life and just trying to take an edge off, Brisdal does actually get marketed at a very, very low dose of Paxil, 7.5 milligrams, really pretty low.
So not something that somebody will be, potentially addicted to or create a dependence on. So that's really good to hear. And Dr. Huang, is there anything you wanted to comment with regards to these treatments?
One thing I wanted to mention is that because we talk about wanting to keep our bones strong, especially in the menopausal years, is if this may be helpful to assess for vitamin D proficiency. And there are vitamin D supplements available for women who have a deficiency in vitamin D.
Yeah, there's actually very commonly stated in the alternative medicine for menopause treatment is to up your dosage of vitamin D either through these supplements. So that is very true. Any one of these probably deserves their own webinar to go into more detail on, and I appreciate both of you just briefly going into them now. We will also be going briefly into hormone replacement therapy. Could either one of you go briefly describe the risks for hormone replacement therapy? When is the best time to also start it as well?
Dr. Huang, you want to talk first?
Well, I would love to hear your perspective. I sometimes have women who are not able to take systemic hormones safely because they've had a hormone receptor positive cancer history, for example. And so in some cases, vaginal estrogen is a very safe alternative because it's such low systemic absorption and can be so helpful for the significant vaginal symptoms and urinary symptoms. So yes, there's no risk in vaginal estrogen for the most part. It actually is really considered just a local management. There's some really nice low doses on vaginal estrogen. So for many women who have vaginal symptoms or they've got bladder symptoms, they're having a discharge, the vaginal estrogen is a really nice option. And there's so many ways now to give vaginal estrogens that it's just really a menu of choices for them. The systemic estrogen replacement therapy is a lot more complicated. It is a big, long conversation, and it does require a very personalized, significant risks and benefits discussion with your physician to make sure that it's the right thing for you. But in general, when we just talk about the risks of systemic estrogen, I think we can narrow it down to two potential risks. One is the cardiovascular concern that we sometimes have if a woman has not seen estrogen for more than 10 years and she's been menopausal for more than 10 years, she really is outside that window of opportunity of considering it because the estrogen receptors really haven't seen it for a long time. And it can increase the risk for some cardiovascular concerns, predominantly stroke if they're taking it orally.
And the other one is cancer. We do worry about stimulating the growth of a cancer if someone might have one, because estrogen is a growth hormone, and it grows tissue, healthy tissue. And if a tissue had turned to become more of a malignant cell, it can stimulate that growth too. So it is important, again, to talk with your physician to know if all the appropriate screening tools have been done, mammogram, pap smear, maybe pelvic ultrasound, just to make sure that everything has been fully screened. And so we don't ever want to stimulate the growth of an abnormal cell. And I think that it's also nice to know that the tumors that are known that often have an estradiol receptor on them are, of course, breast and uterine. I think most people do know that, but we don't realize that melanoma can often have an estradiol receptor on it. So can brain tumors, and so can lung tumors. So that a lot of times it's important to make sure that these patients are getting good care, seeing their primary care physicians, and getting all their screening programs done. And then really individualizing it and thinking about why are we looking for? What's the goal? The North American Menopause Society has a blanket statement, which I love. It really should be the lowest dose possible that we need to accomplish the goal we're trying to accomplish for that patient, and for the shortest duration of time.
Yes, very, very well put. And I know this, again, like we said, this is something that could have its own webinar, but that was a great overview of what to know about it. Before we move on, Dr.
And
Huang,
I just want to reiterate,
yes.
For healthy women and who can but benefit from hormone replacement therapy because of symptoms that they're experiencing. I sometimes see a very high level of fear, and I don't think that it's something that people should be fearful of using in the appropriate situation. It shouldn't be. It has many extensive experience with usage, and we know how to use it safely. So just wanted to put that out there.
No, it's really important to mention, because there is the prevailing belief that in some circles that the hormone replacement therapy contributes to a breast cancer risk. And I think both of you have just clearly stated that with an individualized care plan and knowing exactly what's going on with the individual person with regards to what could be grown, there's no way that something like that could occur. So that's why it's so important to know like exactly what hormone replacement therapy will do for you. And obviously it's something that will be brought up during somebody's care plan. So that is really great to know. So I'm just trying to make sure that we have time for the Q&A. So I will just be moving forward briefly to the resources that I would recommend people go to for more information on their own. I also use these resources to compile this very presentation, and I chose them for their accuracy and reliability, and I did get the go-ahead from both Dr. Huang and Dr. Hagberg approval on these resources. This is the Medline Plus database, has a great resource on menopause as well as descriptions of menopause symptoms. We've mentioned this one several times, the North American Menopause Society, or NAMS. They have a whole patient portal full of instructional videos, very helpful and comprehensive pamphlets, and even a little interactive map with questionnaires on it based on your symptoms, should you be asking your healthcare provider more about this. So they really go step by step with people on what to ask and what to look out for. We also have the American Cancer Society. They have, when you put in the search bar menopause, they will have certain pages discussing specific risks that may be involved regarding cancer. We also have the hormone.org, or the Hormone Mental Health Network. That goes into a lot more detail about the same amount of information that, for instance, NAMS would provide. They even have their own interactive map as well. And one of the ones that I did not know about was Madame Ovary, which is a blog created by Dr. Minkin, which both Dr. Huang and Dr. Hagberg are very familiar with. So that is what, could you describe just a little bit what's on this blog and how you happen to know Dr. Minkin?
So Mary Jane Minkin is a physician at Yale New Haven Hospital, and I trained under her as one of the residents up there. She's a riot. She's hysterical. She's very honest. She's very blunt. And so she created this blog, Madame Ovary, and she's frequently on some of the the radio shows. I often just flip it on to Dr. Radio, and she's on talking about different symptoms of menopause. She's quite knowledgeable. She's very funny. She's entertaining. I feel like everybody should know Mary Jane. She's just hysterical, and it's a nice resource. I love the North American Menopause Society website, menopause.org. Love that. It really has a great resource for women. There's a whole area on there that's called Meno Notes, and
Yes.
it often hits at lots of different topics. Hormone replacement therapies on there, which is nice, and there's a whole patient section that really can address a lot of the symptoms of hot flashes, vaginal dryness, problems with intercourse. It's really a nice resource for patients, I think. And I love estradiol. I think it's a great hormone for women. I think it solves a lot of concerns, and I think everyone should be a candidate, or at least considered a candidate for it, to see whether or not it might address some of the symptoms that they're having. But it is not for everybody, and it's not needed by everybody. Like I said, it's really not everyone has symptoms going through transition. They do just fine. So there's a lot there. It's a great resource to try to figure out what might be best for you as a patient.
Yes, and estradiol is mentioned in more detail on the Hormone Health Network as well. So those are two great resources to investigate on your own. All of these avoid some of the medical jargon that might prevent somebody from being able to research this on their own, but this is why I chose it, because this is something that the everyday person can read and comprehend. A lot of their resources are formulated in a Q&A type of questions. So they'll probably have something that you wanted to ask already answered and stated. So obviously my book recommendations, I'm going to start with the Menopause, a Comic Treatment, which is what I've been kind of showing through panels all throughout this presentation, is what I would personally recommend as a book, to know like exactly what experiences you might expect during menopause. And then I also, it's hard to read this a little bit, but this is a Women's Guide to Menopause and Perimenopause by Dr. Mary Jane Minkin, who we just described. Very knowledgeable, very astute, very insightful person to know with regards to menopause. And I also have the Mayo Clinic's The Menopause Solution, a doctor's guide to relieving all these symptoms that we discussed about in these presentations, just to give you a little bit more detail and insight onto that. Healthline.com has a list of best 10 books about menopause. All three of these are mentioned on that list. You can peruse the rest of the list on your own. And I just wanted to mention in Madame Ovary, her podcast on her website is called Lady Parts. And I did listen to a couple of the clips, and she is really funny. And she just is able to explain these kind of complex things very well, just as my guest speakers were able to tonight. So if you want a little bit more of what we were tonight from another great expert, please check out her podcast. It's available on her website and also on your app store on the podcast app for any of the phones you might have, Android or Apple. And I just wanted to conclude before we go to our, sorry, we're a little bit low on time, but just wanted to conclude with one more panel from the comic treatments. So the theory that the author wrote in this is that the purpose of the hot flashes are doing something else. They're not meant to cause you pain. They're actually give a shits burning off, excuse my language. And that postmenopausal women report a sense of freedom not known in younger years. So that's what hot flashes are for. They're burning off give a shits, what people think of me, not asking for help, chin hairs, imperfect body. That thing I said back in 92, my need for approval. I need to be awake to notice, realizing this made me ridiculously happy. So I just thought this was a great way to end this menopause webinar because, one of the reasons that it can be hard to talk about is because there's a lot of negative stigma and misunderstanding. Got to approach sometimes these health things with a little bit of on the lighter side, with a little bit of comedy. It can help a lot of people out with that. And I'm sure Dr. Hagberg and Dr. Huang would agree also with the sentiment presented in this panel. And I'm really glad that I would really hope that somebody would check out this comic just for the comedic side of this alone. So with that being said, thank you so much for attending. I'm going to look at the questions that were asked. I know there were a couple in the chat. I'm just gonna go through them one by one. So, yes, so the recording, can we get a copy of the slides? I did send out a PDF version of this presentation prior to the webinar to those that registered. But if you did not receive it, please feel free to email me. My email is listed right here on this slide. And then I will be posting the recording on my website, and I will be sending an individual link to all the registered people once our AV technician sends me the link. So in a couple of days, it'll be ready, and I will send each person who registered for this webinar the link personally. And if you go on this website, the Stephen Mickley Community Health Resource section, it's also going to be posted there. That's the website that I manage. So that's where you'll be able to see it. It'll be ready in a day or two. Okay, so some of the questions are here. Is there a way to postpone menopause? My mother got very depressed and miserable after menopause. I want to postpone it as much as I can. And the person has so noted that they are 44. Dr. Huang or Dr. Hagberg, either of you want to take a minute on this?
I'll jump right in there on that one. So yes, the loss of estradiol is linked with the onset in many patients of depression and anxiety. So we want to try to, again, maximize that patient's production of hormones during the early perimenopausal years, when the ovaries are becoming less responsive to the brain stimulating hormone. The follicle stimulating hormone will continue to rise until the ovaries do kick in again. And that up and down and oscillating rise and fall of estradiol levels can be very confusing, traumatic even to the body to be trying to figure out what is going on. So to maximize that, it brings us down to the exact same things that we had really focused on early on, which is nutrition, and really pulling back on the inflammatory components of sugars and the saturated fat. So it's really eating a lot of vegetables and a lot of protein, exercising on a daily basis, keeping a routine going with that, because exercise improves blood flow, and that blood flow is going to get up to the brain to help the brain function as much as it can during those early years. Getting enough sleep. I know I mentioned that before. I'm just a big fan of getting enough rest. I think it's important to reset everything. And sometimes it's actually stress management. Lastly, as far as supplements go, if you get most of your supplements through your food groups, I think you're doing really well, but many people don't. So occasionally we do talk about adding in, and I think Dr. Wong had already talked about vitamin D. I think that's a very important one, not only for bone health, but it has a lot of other benefits as well. Vitamin C, vitamin D, zinc, vitamin B, all of those can be very helpful during those years. And then you talk with your gynecologist about any other potential things that can be offered that are very natural, just to try to help get through that. Sometimes it is talking about antidepressants, and sometimes it is talking about very low dosed estradiol replacement, even putting on a combi patch if it's PMS, or some sort of hormone balancing during the days that you don't feel well, if it's really early in perimenopause. And then later on, they can always talk about a little bit more of an advanced therapy.
Mm-hmm. Okay, hopefully that was, definitely don't want to experience the depression. I don't want anybody to be anxious that that's what they're going to feel. So hopefully any of Dr. Hagberg's recommendations that she just did will be able to help you out. The next question is Estrada the same as estrogen? I'm not really sure if that's
Estradiol.
Yeah,
Yes.
I think that's what they were referring to.
So there are a number of different types of estrogens, and estradiol is the main estrogen that's coming out of our ovaries during our reproductive years. It also comes out of the adrenal glands as well. So ovaries and adrenal glands, and it's metabolized to another estrogen called estriol. And then there's another estrogen in the body that's called estrone, that's made in the peripheral fat cells. That's not a healthy estrogen at all. But there are a lot of different types of estrogens. And you're right, estradiol is the main estrogen that's made in our reproductive years coming out of the ovaries.
Dr. Huang, I don't mean to leave you out of these questions, but if you have anything to add, please just jump in. I'm also trying to be okay with the time because I don't want to keep you guys over. Is there anything you wanted to mention so far?
Yeah, no, I agree with the answers that Dr. Hagberg gave. Yes, and there is still production of estrogens after menopause. And in fact, sometimes it's undesirable if a woman is obese, that there can be an excess amount of estrogens produced in the by conversion of the adrenal hormones in the fat cells to estrogens. So I agree with that. And so trying to maintain a healthy body weight and as Dr. Hagberg mentioned, the nutrition and the physical activity, things that are anti-aging for the whole body can also help to support ovarian function.
Okay, well said. Next question we have is, why is menopause as 1 year with no blood? Can it be more or less?
That's just the definition. It's clinically defined as 1 full year of no periods. And then they have transitioned into menopause at that point.
And I think any kind of abnormal bleeding we said was also a symptom of specific gynecological cancers. So obviously if there is abnormal amount of bleeding during that time, that's something that should be, looked into, at least from what Dr. Huang told me.
Yeah, there's parameters of normal during the perimenopause that are followed to make sure that they're not having too much bleeding or too often. Once they've transitioned to menopause, they should not have any bleeding at all. As Dr. Huang had mentioned, that deserves evaluation with the gynecologist.
Absolutely.
Next question is, can menopause be delayed for pregnancy? That's an interesting question. I guess in a hypothetical sense, what would either of you say to that?
Well, currently there's no way to there's no medical way to delay the onset of menopause. It's intrinsic to your body. So I guess, I don't know, I'm not sure if I understand the question, but maybe in the future, there may be interventions that could help prolong ovarian function. But right now, we don't have that capability.
Yeah, unfortunately,
there are ways to preserve fertility prior to undergoing, for example, if someone needs surgery, there are ways to preserve oocytes, the eggs, or to preserve embryos for future use. So there are ways to preserve fertility that are alternatives.
Oh, I'm sorry, Dr. Hagberg, did you want to mention anything? I thought I saw you wanting to say something.
Yeah, I was just going to mention that there are a few things that the gynecologist can do to look at ovarian reserve, like a bank, to see how many follicles are in there on ultrasound. And there's a blood test called the AMH, or anti-Mullerian hormone, which can sometimes give us a hint as far as how many follicles we still have left. And we don't normally suggest testing for that. It's usually done through the infertility clinics, but every once in a while we'll have someone who is approaching a little bit more of an advanced age. We do suggest the egg freezing after a certain age, just to bank them, just so we have them in case. And then once they hit the menopausal years, I think the question was, once you're in menopause, you're no longer ovulating. So you're no longer considered fertile, and you no longer need pregnancy prevention either. So they can certainly do a lot in those infertility clinics with egg donors, surrogate uteri, and lots of options for fertility enhancing. But once the ovaries have declined in function, there's no longer any ovulation that's happening.
Okay, hopefully that answered that. Next we have, I guess I'll take over this one. I know this webinar is about menopause, but as a woman approaching menopause, are the resources different from the ones you mentioned for women already in menopause? And I can answer that. The ones that I mentioned in the slide, let me just go back to that really quick. So all of these resources have sections specifically dedicated to women who are already in menopause. There's sections like that will specifically say, are you in the starting phase of it? Are you in perimenopause? Are you in the menopause, or are you post-menopause? So based on which stage you choose in these websites, it's going to give you information specifically on which stage that you'd like to know about. So if you're already in there and you just want to manage symptoms, there's a specific page on these websites just for that. So these websites are a wealth of knowledge that will cover pretty much any question you might have, no matter what stage you're at. So I think that's the best way I can answer, unless Dr. Hagberg or Dr. Huang have anything else to add. Okay, so I'm sorry to keep you a little bit past. I'll just give you another question that I see on here. Are you both able to see the questions yourselves? Perhaps I can, yeah, if you just click the question and answer bar on your toolbar, you're able to see the questions as well. I just want to make sure that I'm asking the questions that you're most able to answer. So is there anyone that sticks out to either of you?
They're all great questions. They're all
I agree.
They're all great. I'm trying to rail right through these. So is having a period for a few straight weeks straight a symptom of perimenopause? No, that's abnormal. So there's certain parameters of normal. You're allowed to have a 7-day flow, and you shouldn't flow longer than 7 days. And your period interval from the beginning of one to the beginning of the next one should not be shorter than a 21-day interval. So if you consistently have cycles that are too often, and they're, every 20 days, and that's been going on for 3 times, that's abnormal. Or if your cycles are consistently lasting longer than 7 days during the perimenopause, that's abnormal. Both of those really should be evaluated by your gynecologist. So if someone has only an adrenal gland due to a nephrectomy, would it be a problem? Cool. Well, that's a great question. I think the reason we have 2 of a lot of these different organs is because the other one can really make up for it. So same thing with the ovaries. If you lose one ovary, the other one can usually compensate for it. So I have not seen anyone showing a lot of real adrenal issues if they've had one of the adrenal glands removed. Is it true that your menopausal experience will be like that of your mother's? What is true on that is that people often follow the date or the year, the timing of transitioning into menopause that they did with their mom. So if mom went through menopause at 51, the average age, they may go through around the same time. If their mom continued reproductive years until she was in her late 50s, then that actually may continue to be genetically similar to yours as well. And polycystic ovarian syndrome, what happens to someone who has PCOS? All right, this is a great question. So PCOS is really not an ovarian problem. It's really a receptor problem. It's a dysfunctional receptor, not just for the ovarian hormone of luteinizing hormone, but also for other hormones as well. So patients with PCOS continue lifetime to need to follow all the rules that we were talking, eating healthy, exercising, taking good care of yourself, because the dysfunctional receptor for insulin can continue to give a little bit of trouble in the menopausal patients, even when the ovarian component of PCOS is no longer an issue for them.
Just going through one by one, Dr. Hagberg, you're doing so well with these questions.
Flax seeds or pumpkin seed to delay menopause is a myth. It's never been proven. So it's never been proven that that's actually going to necessarily delay menopause. But I believe that eating a very healthy diet loaded with just a lot of good, healthy nutrients will support the ovaries to function as long as they can. And hopefully that gives us our own estradiol being produced and transitioning into our menopausal years when we're no longer reproductive.
Flax seeds are also a great source of fiber.
Exactly, yeah. That's important to maintaining a healthy lifestyle as well, getting enough fiber. So I don't see that as being truthful. So are there any other questions? I really love the questions, and clearly both of you do as well. But I do apologize that we're a little bit over our time, as we stated, and I don't want to keep you any later than you have to. So just so everybody's aware, if you'd like to register for more of these type of webinars from the Greenwich Hospital Medical Library and from other departments in the hospital, this is the link and the number you would call. We're going to be having some in the summer. We will be having some in the fall as well. And again, like I've been stating, but I'll reiterate, there will be a recording of this webinar, and it will be posted on this link, the Stephen Migley Community Health Resource section. It'll also be posted on Greenwich Hospital's Facebook and all of the social media pages, including its YouTube page. And I will individually send a link of each recording to everybody that registered If you attended tonight and you did not receive a link from me, just please email me at this email, veronicabelenkin@greenwichhospital.org, and I will provide it for you. I want everybody to be able to watch this great webinar that happened tonight. So I'll just conclude by saying thank you so much, Dr. Huang, Dr. Hagberg, for all of your expertise and insights, and just how detailed you were able to go in to a very complicated health concern. So thank you so much for joining me tonight.
You're welcome.
It was a pleasure. Thank you so much.
Yes, and thank you everyone who attended as well. Thank you for your patience and for sticking with us even as we went over time, unfortunately. So with that being said, have a good night, everybody, and enjoy your evening. Bye-bye.